We're live.
We're live.
What's up?
Hey, everybody.
Our deck is still uploading. Because we have been minute by minute updating all of our news, which is happening every 15 seconds. So we also have special guest Chris here, who I guess he's we don't know what's going to happen. He's going to tell us some stuff probably, but okay, Chris, we're going to send you back. You're going to introduce yourself later. It's going to be amazing. Melissa, what do you have to tell us?
What am I doing? I don't have anything to tell you. It's like the world's on fire. Let's talk about it.
World's on fire. Let's
world's
talk
on fire.
about it.
Yes,
Okay.
I feel like that should be our opening line today. All right. Is the news uploading? Are we doing things? Is it there?
Yes.
Are we there?
The news is uploaded, so we'll send you away. Okay, so here Lisa and I are playing basketball because March Madness apparently. I don't know, but got a lot going on. We got a little bit of real industry news, but mostly government news, which runs our industry. In case no one noticed, so Lisa, give us an overview, and then we'll go into the newsy news.
It is.
Or should we just go into it?
I mean, there's nothing else to say beyond. We are just like you, like drinking from the fire hose of news and waiting on today, which was, RIF Friday or whatever. But that's also been like every Friday for the federal government. And, why does it matter, right? Like, as Kat said, like so much in healthcare technology, healthcare in general is driven by, policy and what the feds are doing, and what the states are doing is driven by what the feds are doing, and so on and so forth. So that's why we care. And it's very chaotic.
Yeah, chaotic, I feel like is the move. So we'll just kind of like maybe go in order, and then we'll tell you what we think about things. Everybody heard there's going to be this big riff. I think that 2 weeks ago, we heard it was going to be Friday 2 weeks ago, and then nothing happened. And then everybody said it was going to be Saturday, Sunday, and everybody kind of forgot. So, and then we saw a couple things. I think this was Wednesday night. We saw that the states had the feds had clawed back a lot of that ARPA money, not ARPA H. Remember, there was like a whole different like recovery act during the pandemic that gave the states a lot of money. Many states had not spent it all. There was limited guidance on it when it was distributed. So they were using it for some, I think, really cool programs, a lot of maternal health things, but like, as you guys know, like we don't care about moms in America. So, that stuff got canceled. Most states just canceled anything they had going on. We also saw like a bunch of SAMHSA money had been clawed back, which maybe was potentially related to the next day, on Thursday. It looks like the Wall Street Journal, got the exclusive. Maybe this was an intentional exclusive, maybe it wasn't, but they saw a bunch of the documents related to the reorg, with 10,000 jobs being cut allegedly today from HHS, and a pretty hardcore restructuring of HHS.
Let me pause you right in the middle to say, Kat was making a joke about Signalgate. And let's just say this is the second call, webinar, meeting, live show that Kat and I have been on today. The first one was semi-private. And let's just say anybody who has news, we should put this out there. You can always find us on Signal. We're on Signal. We use Signal. We'll put it on the actual, on LinkedIn or whatever. We actually use Signal all the time, as does literally everyone in the government. And we welcome you to add us to your Signal chats. Signal, send us a signal with whatever kind of information you have. We are here, and we will do whatever you want with it. We will keep it in our hearts of hearts. We will share it with the world. You just let us know. Signal us.
Yeah, so we exclusively talk on Signal. Right. The only time we don't talk on Signal because our chats disappear is when we have to send each other something like our
travel plans.
It's been since we've known each other. So, we're like old school Signal users. So, and I'm delighted to find out, although I feel like we already knew this, that we are on Signal with apparently the entire federal government. So
correct.
It's freaking great. I'm here for it. Yeah.
We're here. Yeah. Add us to your chats, secretly, not secretly, whatever you want. Just add us.
Yeah, we are here for it. I will also say I was
Great.
talking to like a real security tech pro about this, and his opinion was he's actually delighted, other than the fact that they added a journalist. Whoops. He was like, I'm delighted to know the federal government communicates hardcore plans on Signal. It's definitely more secure than anything the federal government has created. And I was like, I mean, what do I know? I'm just a girl on the internet, but but I think it's probably less easy to add a journalist to like some real government system. But like, what do I know? Lisa, you know, I've worked at the government. But anyway, yeah, you know, send us some signals. We're like on there. Anyway, so there was like a pretty massive reorg announced. So Lisa, give us some of the highlights.
Oh man. So some things we're just hearing that may or may not be confirmed as well as today. But first of all, they created a new administration agency within HHS called AHA. What is it called again? AHA is the Administration for a Healthy America. For a Healthy America. And they moved a bunch of stuff within there.
Like Healthy America.
Yep. Including HRSA, which is in charge of all of the country's federally qualified health centers and also does some regulation of community health centers. Bunch of stuff in there. They are moving a bunch of stuff around CDC. Some of it's been announced, some of it's not been announced. I've heard that they're moving sort of the non-infectious disease stuff in CDC to NIH, but I don't think that was part of this official announcement. So there's just like a lot of stuff going around. They are really like moving things around and reorganizing them and in some cases cutting them. So it's pretty comprehensive. There's questions that we've talked about here on this very talk show about the future of the tiny little office called the Office of National Coordinator for Health IT, which was previously reorganized into the Assistant Secretary for Technology Policy, ASTP. I think no one's even mentioned it in any of these announcements, which is like a little bit of a burn, but I would assume based on the sort of reorganization and cutting that they are definitely cutting ASTP, although again, it's not been actually announced. We understand that there is like an internal battle of sorts between whether this thing stays, if we've discussed on the show, whether it stays within HHS proper or moves to CMS. And as far as we know, that has not been resolved yet.
Yeah, it has not been resolved. I think, Lisa, do you feel like there's no world in which ONC is a standalone agency?
I feel like there is no world, there is no universe I can imagine right now where ASTP remains. I just, it doesn't make any sense. There's been cutting and moving. And one of the things you talked about previously was HRQ and ASPE are basically merging together under a new Office of Strategy, so to speak. So like they are a Secretary of Strategy. And so a bunch of stuff is being like conflated and merged. And they didn't even mention ASTP. So like the idea that that would stick around feels unlikely.
Agree. Feels unlikely. But we will see because y'all, we hear new information every 3 seconds. Like we don't know, we don't know who's actually making the decisions. Someone tells us they are, and then some other guy shows up. Let's be clear, it's almost always dudes. So like whatever.
Well, there was one of the other things I forgot. I was just looking at my post about this. Is that the ASPR, which became its own administration in the last 4 years, which is the Administration for Strategic Preparedness and Response. They're doing like the drug stockpile, like emergency management, like, you know, like there's a bioweapon or whatever, like those are the guys who would deal with that. They're actually moving that to the CDC as well. And again, just really trying to like coordinate, organize, and consolidate a lot of this work. You know, as you might imagine, the people who work on this, like, will be like, here's why you can't do that. I mean, true, but like also it's just happened. I don't know what to say.
We don't know. We don't know. We do know. I mean, those cuts the numbers are published by the Wall Street Journal. So check that out. It's a pretty comprehensive piece, I think. Like, it seems pretty accurate as compared to the HHS announcement that we're looking at right here, at least the first couple paragraphs. So not great. CDC is going to be cut a lot. NIH is going to get, slashed. And allegedly, we don't know if this is true, y'all, because like we don't know any of the rumors we hear are true. But we did hear that at 3 p.m. RIF notices did start going out. But then we also heard that they went out earlier, and then we heard that they're not going out at all. So like, I don't know. If you guys know, send us, signal us. Like, go on Signal, send us some information. But yeah,
I just changed my signal code. It's now LBB.22, just in case anyone wants to know.
Just in case. I mean,
Just
yeah.
in case.
Okay. Also, I'll say, you know, the ASPR, or not ASPR, I apologize. The ARC and ASPE, right? Those are the two that are merging to opposite strategy. I will say merger is an interesting word choice because we also know that ARC is being cut by 80 to 90%. And almost allegedly, again, I believe the 80 to 90% cut is true. As far as like what's sticking around, we've heard that all health services research grants are canceled. So merge is an interesting word because I'm not sure what ASPE is merging with, but you know, hopefully something is left there. Other interesting things, we just saw it in a stat plus alert that BARDA is merging with ARPA-H. But I have been signed out of my account, and because I did not take Lisa's advice soon enough and sign up for a password saver, I do not remember my password and have to reset it live to read more about that. But that is, in fact, what it said. So I think I took a quick screenshot in there. But anyway, anyone with Stat Plus, like, let us know.
By the way, just in case you don't know, BARDA is really important, right? BARDA is this it's a biomedical I forget it's the biomedical version of an ARPA, right, where they're doing they're accelerating the development of biomedical medical countermeasures rather. And they're the ones who did like Operation Warp Speed, getting the COVID vaccine out there. Yeah, thank you, friends. They're the ones who were literally in charge of Operation Warp Speed and do incredible work. They're really important. I would say ARPA-H is newer and doing some interesting work, but it's not quite the same. I get that there might be there probably was a temptation to bring them together. There's reasons why people didn't do that in the first place. So we'll see how this all goes.
Yeah, Lisa, why didn't they put them together to start?
Because it really, again, BARDA is very tightly focused on medical countermeasures and was really part of the ASPR, like emergency response, like health response group, and again, just really more narrowly targeted. The original vision for ARPA-H was a lot broader and meant to be different. But then, you know, the way ARPA-H was actually implemented as like sort of independent, quasi-independent part of NIH, like, it just, everything changed in the period between the idea and like actual implementation. So I don't know, maybe this is the right move. I certainly don't want to see ARPA-H or BARDA go away.
Yeah, well, hopefully, unlike the ARC-ASPE merger, there's more to merge in this scenario. That would be ideal.
Yeah.
And then we heard through Signal, through Signal chat, that OMH broadly within HHS had been eliminated, as well as CMS's Office of Minority Health, and Politico confirmed about an hour ago that is in fact true. So, like, not great. Yeah, some other things. So these apparently were straight up eliminated. Not ideal.
But also, like right here in the headline, like, the reason why HIV is still an issue in America, even though we have really powerful, medical countermeasures and drugs and treatments, right? We have PrEP to stop people from getting infected. We have really incredible drugs that treat HIV and reduce viral loads to a level that you would consider to be almost a cure. I'm obviously not a doctor, don't sue me, whatever. But like, you know, we have incredible drugs, we have incredible treatments, certainly not a full cure for HIV or AIDS, but like just incredible ways of treating this disease, this virus that, you know, like, whatever, like, we have all this great stuff. The problem is that like people have different health outcomes because of their situations, because of disparities in how they live and their socioeconomic status, where they live, their access to healthcare. That's why it's still an issue. So the idea that like, that you would just like stop addressing this through, you know, cutting these divisions and departments and critical research efforts and critical treatment efforts, is just like heartbreaking. God.
Yeah. Yeah. So other news that I actually didn't copy in here just because it was so many days ago. And like, I mean, we're on airport time, y'all. Like, nothing matters.
Right.
You can drink any time of the day. Also, I was drinking actual tea, not alcohol, with Alex Full Mathematica, and he was like, it's like pandemic rules. I feel like that is actually true if you work anywhere sort of adjacent to the government. But Susan Menares was nominated for CDC director. She's currently serving as the acting director of CDC. She is from ARPA-H. I think initially people were like, oh, like she'll get confirmed, like that, definitely more, at least from what I understand, more centrist than some of the other candidates. So I guess the theory was that she would be more easily confirmed, but apparently the Maha people are pissed because she allegedly supported vaccines.
Well,
so
obviously she supported vaccines. She's a longstanding scientist working in HHS, and okay, I don't think that's bad. Hopefully she gets through, but we'll see.
Yeah. So tricky stuff. Also, this was earlier today, before some of the other drama. There are apparently the DC appeals court has said that Trump can actually fire, those appointed to the National Labor Relations Board and the merit something, which allegedly clears the way for him to just fire a bunch of people. So I don't know, Lisa, have you read that one? I clearly just copied the headline here. So TBD.
No, but I mean, this is all the question of like, is this legal? Is this not legal? As you've said, like, I mean, as it's been made clear, like the administration is making changes, and looks like they're in many cases not asking whether it is legal per se, and they're waiting to see what washes up in the courts. And here's an example of the court saying this was fine.
Whoop, whoop, whoop. So we'll see. Yeah. Also, related to all those federal workers who were hired back or being hired back, there's obviously the Trump administration continues to fight that. So there's just like a lot of who the hell knows what's going on right now. Yeah. So yep. I don't know. What else we got going on here? So, let's wait. Do we have any more like federal news, or can we gossip about like general bullshitty profit stuff?
There's like one more thing. One more thing on federal news. There's a piece that just came out in Axios like recently about the kind of, as people have heard, like Congress is working on a funding plan for the government longer term, working on appropriations. And they've been talking about, of course, the planned cuts to Medicaid, which we've talked about a bunch here. And we've talked about why that's important and how it's going to affect so many people across the country, both in the receiving care and everything else in the technology and healthcare administration world. But basically, like, it sounds like they've kind of come around full circle in the White House and in Congress, the Speaker's office, to be like, wait a minute, if we do a big tax cut for rich people and we cut Medicaid, people are going to be unhappy with us. And it's like, yes.
What?
So it sounds like they might be giving up on some of those tax cuts, according to Axios's reporting, which is, again, I agree, right? If you say like, we got to cut back for all these reasons, and then you also give like this huge tax cut to rich people like Kat, you're going to get some backlash.
I'm definitely the target. Me, all the tax breaks are for
do
me.
not cut Kat's taxes, whatever you do.
I love paying the taxes. I love them.
That is not
so much. Also, Alex Cole, yes, you have made it. Why you sent me that on iMessage instead of Signal, where Palantir can read it, I don't know. But I'm glad that now everybody knows in the entire everywhere that you made it on the talk show. And that is true. We love you.
Amazing.
Yeah, actually, Lisa, I think I met Alex through you, or I don't remember what happened.
Yeah.
But anyway, that guy is he's just part of the team. So that's fantastic. Okay.
Yes.
All right.
Okay. That's enough. That's enough of that. I just wanted to say that apparently they're having a little bit of heartburn about cutting Medicaid and also doing a huge tax cut for rich people like Kat McDevitt, who is their top target.
I freaking wish. Listen, well, as my friend Bill Charnetsky, head of, I don't know, he's got a long title at Point Click here. That guy's like
noted Canadian.
That guy's like a lobbyist. That guy. Yeah. He's like on time. He always says, he's like, Kat, do you know what politicians care about? And I'm like, oh, I don't know, like the health of their constituents. He's like, no, getting reelected. So I think that is coming into play here, maybe a little bit. Right. We'll see what happens. I don't know, like whatever. Figure that out. Okay,
I agree.
And just like America, just so you know, like if you're in the private sector and you're like, fuck the government, there are things here that are affecting you. Like a lot of this funding does really trickle down, like in a pretty serious way. So if you haven't felt it yet and you're working in healthcare, you probably will. Also, even things like ARC, a lot of the research they put out is used by many of our friends in venture funded health startup land. So, like, the world is going to change and it does affect you. So I do suggest you start following the money a little bit, or following where you get certain things that are going to be no longer available. And if that makes you sad, you should advocate for those things. Just saying.
Yeah.
Matthew Holt, always on the internet saying stuff, who we have come to know and love, even though he does sometimes post douchey things on our posts, whatever.
He does. He's going to come on the show again soon. Yeah. He's going to, he's advocated successly for himself.
He's like almost a regular correspondent at this point. This will be like his fourth or fifth appearance. Anyway, he actually, Matthew Holt does post douchey things sometimes, but he's like pretty smart. And I do appreciate that he just says what he thinks. Like everybody knows we're here for that. But Lisa, tell, because you actually like pointed this out to me. Actually, what you pointed out to me were the douchey ass comments.
Oh my God. Okay. So first and foremost, we think we talked about it last week, Hinge Health is filed or is going to file for IPO. They're supposed to IPO sometimes in April. It's a big deal. It'll be the first big IPO in like health tech, digital health in quite a while. People are all looking towards it. Now I heard some little rumors that it might be on ice, which personally, if I were going to go, like, not a great time to IPO in the public market. So they may be getting some cold feet, TBD on that. Their biggest competitor in the space is Sword Health, who is pretty big as well. And, around the same sort of tenure, started from out of the company was founded and started in Portugal. So the founder kind of had the experience of being a smallish Portuguese health tech company and then kind of going and like taking a huge part of the US market, and kind of, just a founder story of like persistence and all that stuff. So Matthew commented, I think on HTN about Hinge Health and Sword Health by giving he's written up his personal experience of being a Sword Health a patient, customer, whatever you will, and just some criticisms of like, was this worth it? Did it really work? Did it do anything? Did it save the health system any money? Just interesting personal experience, like nothing actually very weird about that. But then he posts this on LinkedIn and just gets the full fire of people who were trying to defend the Sword Health guy, and then the Sword Health guy himself. He goes by V. And he's talking about this lawsuit because Sword Health joined the Aging 2.0 accelerator more than 10 years ago and like promised 5% of their equity. Allegedly, this is all allegedly, don't sue me, whatever. And now apparently Sword Health is being sued for their 5% of the company or whatever, taken out to today, which would probably be a lot less than that. And there's a lawsuit. And so he posts this and just gets like all of the static, including from the CEO of Sword Health, who's like, it's not true. This is totally misinterpreted. And he's like, cool, there's a lawsuit. So, tell them, not me. Like, and just gets all of these people like piling on and writing things like, how dare you tear this hardworking man down? And it's like, listen, like you run a like now multinational like health tech company. You raised $1 bazillion. You're not above criticism just because like you were a hard worker and like, okay, I get it. But like, again, this is a public lawsuit. Someone actually said that Matthew was violating GDPR by posting the lawsuit. And it was like, hi, sorry, we are sitting here in the US of A. We have no data privacy protection law. We got no laws here. And also this is a public lawsuit. So like, no, sorry.
Yeah, I think maybe we need to change back our background to something more American, so people just remember that we are in fact Americans sitting in the United States of America. And Matthew is also sitting there. But like, I want to comment, like the riff like totally came out on this post. Like it was like, Jesus Christ. He posted here that you can see at the bottom. If you want to read the lawsuit, which was filed, that's the next one. What? Who the hell is moving this? Filed in freaking California, right? Public. You can look at it on the internet as a human. Yeah, I'm pretty sure, like, I'm not a lawyer.
He fired up the CEO fired up his like Signal chat.
Yeah.
And
he got on his Signal chat and he was like,
yeah. It was like the Portuguese health tech founder Signal chat, which I'm sure it's probably WhatsApp, honestly.
I'm not on it. Oh, it probably was WhatsApp.
It's probably a WhatsApp like
Probably not even
community
Signal.
of like Portuguese health tech founders, like God bless them, like, you know, wonderful country, wonderful people, clearly some very smart people in health tech. They have a whole community there. I'm sure they were like, look at this fucking guy. Like, and they just all jumped on and like,
He's
like
taking us down.
They
Oh my
brigaded
God.
Matthew. What they didn't know is that Matthew doesn't care. Like,
you know, like he's going to get mad that I'm going to say this, but I don't mean it in the same way that he's going to take it. Like, he's a little bit like Elon Musk. Like, he doesn't fucking care.
He doesn't
like,
care. You can't hurt his feelings. Like, good. Sorry, guys. Like, he's
not mad. He's not
look,
mad.
it says right here, healthcare curmudgeon. It's in his like LinkedIn. Like, it's right underneath his name. So
yeah,
nice try, I guess.
Anyway, he's coming back on the show. You have to go check out his LinkedIn post that got our attention, even though he could just signal chat us or WhatsApp us, like whatever. But like he chose to go more extravagant route, which we're totally here for because we are extravagant people. Okay, anyway, go check that out because the comments are the best part, and it's just like what?
So good.
23andMe, Lisa filed for bankruptcy.
Yeah. Yikes. I also saw an alert that I couldn't track down yesterday that like that the company got some kind of court filing to go ahead and sell people's genetic data. Like it wasn't just that they were filing. So I might be totally like making up fake news here, but I feel like I saw an alert and didn't have time to follow it down. So yeah, like you filed for bankruptcy, everybody who signed their terms and conditions originally, it says like basically like if we go bankrupt, our privacy laws are out the window, more or less. So yeah, bummer.
Yeah. Read the T's and C's, y'all. Read the T's and C's. And then in an epic move to throw some shade. Oh, wait, hold on. It's down here. There we go. All of us previously maligned government version of 23andMe.
Still maligned.
Just wants you all to know that they care about your privacy, America.
Right. It's so funny. I mean, I just, whether true or not, it was a class act on their part to send this out today. That was hilarious. Guys.
Yeah. Guys. Your data instead. We won't sell it for as much.
And like, you know, like, again, like, I think as I mentioned before, like you know, I understand the position that 23andMe is in. There's been some really good analyses actually, and also a lot of interesting stuff. Like one of the former founders of 23andMe posted like that's right, we are fire, posted a really long tweet thread. I just can't call it X, I'm sorry. A really long tweet thread about, you know, like about her experience and all the things. Very, very even-handed, like not very friendly or congratulatory to the former leadership of 23andMe, but also just like very thoughtful and interesting sort of what actually happened. So I get the situation they're in. And as far as I could tell from Anne Wojcicki's announcement that she is, you know, going to continue to try to take the company private, even through bankruptcy. So maybe they will be able to sort of like retain and not, you know, not release those data for other commercial purposes. But it sucks. People don't feel good about this. People don't feel good about their data being used like this.
Yeah, not great. Not great. But, you know, in other interesting news that seems good, the FDA approved to give marketing authorization for, it sounds like the first at-home PCR test generally, but also for specific STI testing, which is exciting, right? Like, yeah, that's not bad news.
Yeah, this, I believe, is from this company called Visby, and my former public health school classmate Layla Rumani is a partnership head there, and I saw this on her feed, and she actually messaged me, and I have not messaged her back yet, but I like this, Layla, so I will message you back. This is great. And this is actually, I put this in the same category as the Teal Health thing, the at-home pap smear test, right? Like, I am like, it sucks that we have such poor access to healthcare, especially women's healthcare. But I also feel a little bit excited that we're starting to do more at-home testing and potentially at-home collection of samples for things like this that are really critical for people's health. Like if you have untreated any of the things up here, that's bad news for you in your life. And you know what? If you can get treatment, you can get tests done at home and get treatment quickly. It's better than not having any treatment or any testing.
Yeah, agree. And other slides that we didn't make because like we were busy. It seems that the Health Tech Talk Show has been quoted multiple times by real news
Oh my
outlets
God.
about TEFCA. Oh, y'all, we knew we were in a bad time when you were quoting us.
If you are a journalist and you are citing the Health Tech Talk Show, God bless
Stop.
you, but baby, don't do that. Like I appreciate, like, we want you to like think we're super important and like watch our show, but maybe
Look at
do
our
it.
website.
We're not real news. We're not real news. This is all fake news. Please don't take us seriously. Please go get your citations from the people who said stuff or whatever, not us.
Yeah, don't cite us. That's like, I mean, it's not great. But
or do because nothing matters, and I love it. It's hilarious.
That's
I love
true.
getting.
We are all in an airport together, and I can guarantee I am way cooler as an airport bar participant than any journalist. So if that's what we're talking about here, like, yes. You can quote us all you want.
If you see us in an airport, as people have like approached us in airports, which is very odd. If you see us in an airport and you recognize us, definitely come and tell us like secrets and tell us all kinds of things and say hi. Like, we appreciate that.
Yeah, we are definitely here for it. That is the number one way to our hearts. But yeah, and then in other news, Lisa, I think we're going to live decide this right now, but there is like quite a fight, speaking of TEFCA, on one of our Health Tech Talk Show posts where Don Rucker is saying TEFCA might be illegal. I mean, I think I'm asking him that, and he doesn't exactly say that, but like, and there's like quite a debate. So we're trying to figure out like how we like facilitate that conversation. So we might have a special like Wednesday talk show where we get a bunch of people on and we just hang out and they fight each other.
Yeah, I'm open for a debate or whatever. And I personally, I do think that Don Rucker did say that TEFCA was illegal, but that's just my interpretation. Maybe it's what I wanted to hear, but I was amused by that. Now, just to be clear, TEFCA is illegal is not Lisa's perspective. It's not the perspective of my employer or Kat or Kat's employer or any of her many clients. It is just something that we have heard on these streets.
Yeah. At the airport bar, so to speak.
At the airport bar.
Which is not a real place, at all. So, but I don't know, the people who I think we're going to have on the talk show to fight, definitely Michael Westover, definitely Brendan Keeler. I mean, Don can always come on the talk show because he's hilarious, but if anyone else will, Kristen Valdez is going to come on.
Kristen Valdez is going to come on. Yep. From BWell.
We'll see. We'll like get a good crowd. It can't be too many because then the fighting will not be as dramatic. Like it needs to be like probably 5 or under. So TBD, we will let you know. Mostly it's going to depend on, are you? Oh, that's because my children are playing their gaming computers. I apologize, everybody, but
kick them off. You need to like,
can't
you like rescind the time? Don't you have like an app? You can be like, I'm taking back your time.
I can, Lisa, but then I would have to stop saying bullshit to you and I would have to do that. So we'll see.
Fair.
But next up we have a real special guest. I think we're done with our fake news show. And we have Chris Cruttenden, who is like, I think very important at Safety Net Connect. He's going to tell us.
Hi, nice to meet y'all. I'm president and founder of Safety Net Connect with my partner, Keith Watts, who might be hiding in the wings over here.
Hiding in the wings.
If you have a really good question, he'll probably come out and answer it. So Safety Net Connect is focused on
emotional support.
Yes. He's pouring the bourbon for me right now. We're really focused on access to care, specialty care, and not just medical, but all specialty care access for the underserved, and also the vulnerable populations. And we even feel that if a person is sick, they are vulnerable, and to get the runaround and flipped over walls and not get that access immediately is detrimental to their health and ongoing care. So that's kind of our basis for the technologies we provide to Medicaid plans, LA County, Inland Empire, the state of Colorado. And it's been pretty exciting so far.
So like, how do you feel about all the state funding being pulled? Not all of it, but like some of the COVID specific, behavioral health related, like, how do you feel about all that? How do you feel about that being pulled?
Terrified. But the most interesting thing, just going to the last few health conferences, you watch the news and everybody's fighting it in the public, and then you go to the conferences and you listen to all the talking heads and everybody's pivoting. And there are opportunities. I think that we do a phenomenal job. We save health plans money in multiple facets of care. Patients like having the quick access. I think we play really well in value-based care and where they want to go, but obviously you have to get that message out and show what we've been doing. Right now, annually in LA County, I believe we save across the board for what our system is doing around $68 million a year. And who doesn't love
small money?
No, so
yeah. So what do you think? Like, what would you suggest to colleagues kind of working in this space, right? Like, I mean, you just said like a lot of people are pivoting. Like, is it too late to pivot? Like,
gosh, I don't want to sound bad. Have they really figured out what they're doing in the administration yet?
I mean, I think it's safe to say more cuts are probably coming.
More cuts are coming. If it's just funny, I wish they could get an audience with you or me or some of the people you've had on your show. If I could talk to people at CMS or Dr. Oz or RFK, I'd look at what CMMI has done with these innovation grants. Not all of them were great, but a lot of them were. And the impact on health, the actual savings, the pushing forward of technologies that would have never even been tried. They need to understand that the benefit has been long-term, and we're still enjoying those benefits now. And to just cut that off and kind of say, well, we'll just see what happens. I just don't think it's a great idea, but I think it might be uninformed, and you can't have just a one thought cut mentality without looking at the benefits of everything that's happening. At least that's my opinion. I think there needs to be more hearings. What's Congress doing? Let's talk to people that have benefited. Let's talk to patients that are benefiting, health systems. Let's understand ACO reaches a little better before you just demolish them in the future. How have they uplifted people? What could be improved? So.
Well, I think ACO reach is not particularly being, or at least we don't know yet, of course, but I think ACO reach, besides getting likely a new name, will probably not change dramatically. I'm old enough to remember when we were writing the model description for what was then called direct contracting, and now is ACO reach, and we'll go back to something else very likely. But I think the concept of providing some more flexibility there in contracting and then creating these, supporting these intermediaries like ACO enablers, value-based care enablers, I think that will likely continue. But like we've talked about on the show before, I think that this administration is already signaling that they don't want to pay for pilot programs, for lack of a better word, demonstration programs, CMMI models that are just providing additional payment that are pretty light on, other meaningful changes. Although I will say, like, advanced primary care, I believe in it really a lot, and I think it needs to happen no matter what. I kind of think that the way CMMI models were structured there is the wrong approach, because I just fundamentally believe that primary care should be paid more. Like, I don't want to do an experiment. I just want to pay primary care more and give them fewer reporting requirements. And I think, they're working within the system they had, and it's really hard and painful to see these primary care models cut. And I think it's going to actually meaningfully harm people and communities. And I'm concerned about that. And I share your, cutting isn't the way, but I don't know. I mean, maybe we come out of this with we're just going to pay primary care more. I realize that's probably unlikely to happen, but that's my dream, right? It's not a test.
It should happen. It should happen. And you know what I think about CMMI broadly? Here's another example of where We've all learned that maybe the government is not a business, and that's why we call it the government. But we have this thing out here in the wild. We're like, we gotta fail fast. Let's like do shit and fail fast, LNG, and like see what works and see what doesn't. I think when you apply that whole fail fast thing to something like CMMI, which is trying to impact the nation's health system, which FYI is like not small, I think the mistake we make is like, okay, well, if something's not working right away, let's just fucking cut it, right? And then how else are you going to try stuff? Like, I don't care that CMMI models didn't work, right? Because I think it at least like gave us some value. Like the thing didn't work, right? Let's not do that anymore. And let's cut that out from a lot of our new theories because it didn't fucking work. And I think like the fail fasting is bullshit. Like, Lisa, what's the name of the thing? Is it Accountable Health Communities? Which initially people were like, this is bullshit. It's not going to work. And it just like, they proved out.
And it actually
year,
worked. Yeah. Shocker.
Yeah.
It
and
takes
how many years? It took like,
but Chris, now I'm just gonna steamroll through the entire thing of having you on the show and just say like, the reason why it takes so long.
Sorry, Chris.
Sorry, Chris. We're in ranting mood today. The reason why it takes so long is because there aren't any real-time data feedback mechanisms that anybody has the like cojones to implement, like truly, because they're like, oh, if we put too many requirements, nobody's going to do it. And it's like, that's true. So you need to like help them, like set up those systems, pay them appropriately, and do actual work to try and get people to join your model. Like the recruiting of providers effort at CMMI and at CMS, like never gets, like more than like $1 budget. That's also important, right? So you need systems that give you faster feedback so you can, like Kat said, like know pretty quickly whether your thing is working or not and treat it like an experiment thing. Instead, what we did is we started to create these like longer term programs at CMI, which I have praised. Like the new models that were cut were like 10-year models. I was like, well, that's great. Those are programs. They're not tests. No. And then they're not in CMMI. Sorry, Chris, I just ranted for a long time. What do you think?
How do you feel about that?
About that, Chris?
I'm not going to disagree with anything you say. I would like to see some. They are trying to be innovative in the new administration. Let's flip value-based care on its head and just to be really controversial. And incentivize patients, invest in them. Our experience when we do this thing called e-consult, which is asynchronous, when two doctors are talking about the patient and they tell the patient, we're having a conversation about you, they don't miss their next appointment. They do the test. And it's really interesting when they've invested a little time in their care and they know people are doing that, that the outcomes are way better. And
super interesting.
Like that would be really exciting for me. Everybody talks about universal, when AI kicks everybody out of their job. Not universal care, but incentive-based care where patients are incentivized to take care of themselves. And
okay, so how would that work? Tell us how that would work.
It's a great idea. Let's go. Let's build it out.
It's like, I'm not going to help you.
Let's do it.
No, we're gonna do it right now.
Is it? His emotional support is helping.
I know. He just said, I'm not digging in that hole. I don't know how that would work, but on a small scale, in a Medicaid system where people are being flipped over the wall, you go to your primary care physician and you're like, oh, I don't know, you have to go see a GI doc. I don't know what's wrong with you. Go see him. 6 months later, you get to see him. In that type of situation where you can really say, hey, we're going to have a conversation with the GI doc tomorrow. They're recommending these tests. And I would actually help them get transportation. I might even pay for it if they need to get those tests. I would actually maybe even pay them $20 to go get those tests that day or the next day. And really, the sooner you get the test, the sooner the GI doc gets it, the sooner we can actually create a treatment plan, or we know they're fine and we can get them out of the system because we know there's not anything wrong with them. But on a small scale, little bits like that, I don't think would cost very much. And I think you would have a greater impact on care. So.
Well, yeah. And the government is actually in the best position to do that because the government can create safe harbors and things like that around inducements for patients. the government is the entity who could do that in this type of experiment, whereas in the private sector, it'd be harder to do. There are just more legal issues and practical issues and programmatic issues. So yeah, I mean, I feel like Kat, let's create the Make America Healthy Again CMMI model. What do you think?
I love the branding, Lisa, obviously. So I'm here for it. I think there's a lot that we could do there.
Run by the Freedom Health Data Network. Run by the Freedom Health Data Network.
Absolutely. You know, and some of the, those manifestos getting flung around in like January.
We should write a
About,
manifesto.
oh my God. Why have we not? We could do it in the airport bar, Lisa,
we're lazy.
Where we currently are.
We're mostly because we're lazy and we'd rather just talk about it than write an actual manifesto.
Absolutely.
AI, I'll write it for you.
Great.
I'm nervous about the AI. I'm nervous about but apparently I shouldn't be because AI is coming. But no, so those manifestos flinging around that 1,000 tech bros wrote, and it was all like, apparently like Make America Healthy Again. We're going to make patients like totally in charge. Basically what you're saying, Chris, except that like, we don't know how to do that within our current structure. So that's not great. Yeah, I mean, I think that's the thing. Like, how do you actually make that happen? In the real world
structure, you just focus on the gaps. Where are the biggest issues? What's going on? I mean, somebody who doesn't get access to whether it's specialty care, food insecurity or whatever, and they end up in a really bad situation and cost more services, there's a gap there. Address those small ones at the little different places. Right now, in the different Medicaid systems, they have the structure there, but they don't have the incentives.
So. Are you primarily, what patient population are you primarily working with this e-consult?
We've been working mainly in the Medicaid population. Now we do work with other populations, but our bread and butter, we love Medicaid patients. We want to help them. They deserve just as good of care as somebody who has a PPO plan. And we try to deliver that. And they're really grateful. They love it when, one of the greatest things that we heard, and we had a professor from Harvard do a study on e-consult in LA. And he interviewed all these patients. And when they found out there were doctors having conversations, I mean, some of them almost cried. They're like, I've been just kicked around and I never knew they actually had a conversation about me and what is best for me. And, I mean, Medicaid's tough, especially in an impacted, there's good plans that do a good job, but it's hard. And some of these people are working a couple jobs and have kids, have, transportation issues. So you can't just go to that clinic and go get tests over here and we'll let you know when you get an appointment. It just doesn't work. And so those little gaps, you can improve, you can save money, improve care. The sooner you get people healthier, the sooner they're out of the system, drawing from it.
Yeah, Lisa and I talk about like, you just said little gaps, right? But like, we talk about like little friction points that like make such a huge difference all the time. The transportation one is so interesting. And like, I do worry, Lisa and I were on this like semi-private like presentation thing this morning or this afternoon or whatever. And we talked about like, how you talk about social determinants of health and health equity. Like, are those phrases like illegal? Like, who knows? But I do worry that some things like, making sure people can get to their appointments, like plain language, things like that, get lost in this conversation about social determinants and health equity that's like branded as like, oh, you're a Democrat, like we're going to cut that. And it's a shame because like, that's actually what people need to like get their stuff done.
That's like the fundamental, right? People face barriers that other people don't face. If you literally have a car and money to pay for gas, you have a resource that somebody else doesn't have. And they literally, like, what are they going to do? They're going to magic their way out of somehow, I don't know, getting across town in a place like LA, not having a car and not having access to transportation probably means you can't access any of the services you need access to stay healthy. And you might have to go somewhere completely on the other side of town for, any kind of employment that you might have or any other kind of services. It's actually very real. There's not like a magical thing. Or if you live in a rural area, can't access, there's not even any type of public transportation. These are like real barriers that people face. There's not a magical way to like imagine them to go away. They're barriers that will stop them from getting care.
Yeah, and they just, end of the day, they just go to the ER. for care and service.
Yeah.
Right. When
Yeah,
it's
yeah,
really
yeah.
bad, when it's like they're in really, really bad state. And it's, by the way, they're going to have much worse outcomes. And also it's going to be bazillion times more expensive for the system to deal with.
Yeah. 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 We had one example where a patient was using the ER for their child's asthma. And we were alerted about them, basically helped their primary care physician work with an ENT, and we got them a controller, and they've never had to use the ER since. And you think they're happy? They're so happy they don't want to use the ER. It's a horrible place to go to get a controller for asthma.
As everyone knows, my favorite show at the moment is The Pit. I know probably there are plenty of other fans of The Pit in the chat here. And yeah, they do a pretty good job of showing the experience of going to the ER for care and what that will mean, and why the ER has to prioritize people with like critical emergent issues over somebody who has even a serious issue that is a little bit less emergent. So yeah. There's a comment in the chat, which I'm going to put up here real fast, from Joanne, friend of the show, friend of us, who says the government wants people to be healthy. I understand the sentiment behind this, but this is also just like a question that Kat and I got in our other engagement today, which was just saying, like, you know, some people don't believe that, you know, like abuse is happening, or some people don't believe that, you know, there are these disparities in care. Unfortunately, we do have to, like, for the most part, assume that most people actually want the best for other people around them. Like, I understand, I'm not naive about this, but we do have to assume that the government wants people to be healthy. They have a different perspective. We maybe not agree on everything. We might have a different way of going at it, but we have to assume at least some basic principles. And again, I'm not naive. I really am not, but we have to assume that we ultimately want, like, healthy people, a thriving economy, whatever. Like, we have to assume those basic things, because of the moment you've decided that, like, we don't trust anything or anyone around us, you might as well just give up. That's my, like, soapbox for the moment. But, like, I have to assume that the people who are running the Make America Healthy Again movement, let's call it, do ultimately want people to be healthy. We probably disagree. I probably disagree with them. I'm not seeing anybody else here. I probably disagree on different ways of doing it and particular actions, but, like, the end goal has to be the same somehow. So just, like, I know this has been a really dramatic couple of months, like, feelings are high, emotions are big, but, like, we do have to, like, try to assume that people want positive outcomes, right?
Yeah, pivot to
soapbox. That's just me. That's my opinion. Just soapbox. Sorry.
Yeah.
Go ahead, Chris.
Oh, I was just going to say where we started. Yeah, everybody's pivoting a little. I do like some of the new ideas. I'm scared for some of the old ideas that I think are working. I don't think need to throw everything out to have new ideas. You can kind of layer some on and get rid of the ones you talked about that don't seem to be working. But yeah,
back to, like, the simple, the little gaps or the friction points. And, we've talked previously in Senna, where my real job, Leslie and I donated a bunch of money to Boston Community Pediatrics, which is a really interesting model for Medicaid and underserved patients in the city of Boston. And, it's so interesting. They only, I believe Robin, the CEO, she said that they spend $4 million a year. They're only reimbursed for $1 million a year. She raises pretty much on her own that $3 million gap, which is more of like a gigantic canyon than a gap, right? And it's to do things like you're saying, Chris, like to, a very simple comment from her staff that actually I think is surprising to a lot of people is they were like, what do we do if a mom's car gets towed while her kid is here? And they're like, we go to the impoundment lot and we pay for it to be released, yeah. Right? And it's like simple things like that where you're like, oh, yeah. Or like, hey, the mom can't get here. What do? We send her a lift. And it's simple things like that. We're like, wow, like that makes a big difference. And then once they're there, they have simple things like they have diapers from a diaper bank, right? From another nonprofit. They have socks. Well, actually, they do not have socks. That's one of the things they're missing. So if anyone wants to send this group socks, Boston Community Pediatrics, they will take your socks. But there's healthy meals available there. So just like that one friction point of getting them freaking transportation allows them to have like access to all these other things that like are going to meaningfully make their lives better. It's not just about like, getting their shots so the kid can go to elementary school. So I don't know. I worry about that a lot. Like where there are people like Robin who are just like hustling and making it happen. Great. But like, New York State, their 1115 waiver, huge resources dedicated to fixing these things on a broad scale. And there's a
lot
real
of
concern
money.
that waiver is going to be pulled just because everybody's pissed off that like waivers and money and health equity or whatever the fuck we said, like, whoops. Those are real meaningful things that make a difference, whether you're a Republican or a Democrat or whoever the hell.
Yeah, I want to put up Joanne's follow-up here, which I think is also important to mention, that, it seems like more people make money when everyone is sick. That is like the one thing that I'm interested in this new like non-coalition that has like seemingly formed, is that, there's lots of bad things about this, but there's also one good thing, which is that there aren't as many obvious allegiances to the bastions of the healthcare system. Like, I
don't agree with that statement.
Go ahead.
Yours, the comment. Healthy people make a better economy. I'm sure you've all had people in your lives that are feeling pretty terrible, disease, cancer, or other. You can't do anything. You can barely function. You're a draw. You're a draw on your family. You're a draw on resources. And being healthy and being able to get out there and either donate, contribute, volunteer, or work is contributes to a healthier, a better economy. So, yeah.
I think she's more talking about the huge profits across all aspects of the system. I understand that concern.
I don't know if you can do that, but yeah.
I agree. I think we need healthier people will make a healthier economy. I fully agree with you, Chris. I'm just saying, I think that's what she's pointing at with that comment.
Okay. Strong agree. Also, I will say right now, one thing that I do believe is the government does not want to spend as much. And as the largest purchaser of healthcare services in the world, I believe still, they don't want people to be sick and a drain on the system. So unless we're saying that they want to have the death pods back, I think there is strong incentive to make people healthier. Lisa, I don't know, whatever. That was supposed to be funny. Maybe it's not.
Is there any ideas in the current administration besides the cutting that you've heard that you're excited about? I'm just curious, because I'm excited about one that I think is happening.
Please tell us. I don't think I could say that so far, but I'd love to hear what you think.
The food, focusing on real vegetables and fruit grown in real soil that has actual real nutrients as a method to health. And I don't know what.
So I agree,
but I've heard some of that kind of through the grapevine. Some friends that provide food pantries and whatnot, and those are the rumors coming down on that's a focus, and that would be exciting.
Yeah. I think also for
I do agree.
Local. I think I'll be interested in seeing what can be done to strengthen local food systems, because as you all know, we move a ton of food across the world, across the country, and we have over many, many years and decades have deprioritized, local food production for centralized and agricultural, farming or industrial agriculture versus food production. So that's not a 4-year project. That's a money-year project, but that definitely can't hurt. That would be great.
Yeah, I think like most people know this, I am a strong proponent of eat whole-ish healthy foods, eat foods, mostly plants. Who was that, Lisa? Is that Michael, whatever guy? I'm sorry, but the 90s really fucked us, right? They told us that we can't eat fat and meat is
for
awful.
So many reasons.
But you know what we can eat? We can eat jelly beans because there's no fat in them. Right?
My diet is 15% gummy bears. So it's fine.
Yeah. There were a lot of bad things that happened. And so there's I think RFK is in West Virginia today, or already was, or maybe he's back. I don't know. And I don't know what all the changes that they were announcing with the new governor there, but there was a press conference to talk about we're removing food dyes and there's other changes to SNAP. I don't know what those changes were, but I'm pro not having food dyes, y'all. I'm here for it.
Sure. If there's something that will get additives that you can't sell in any other country out of the food system in the US, sure, absolutely. I'm not against that. I think that people, there's lots of problems in the healthcare system and the food system. And I would be perfectly supportive if we end up getting rid of a bunch of additives that can't even be sold in other countries because they're like so crazy. So sure.
Yeah. But you know what I think is the most interesting part of, maybe not interesting, stressful part of the whole, like, let's have healthy foods, like, let's make America healthy by not feeding us shit. Great. Is that, like, RFK is running HHS. Someone else is running USDA, right? So, like, there still is, like,
Not the same agency.
You know, and allegedly they are collaborating. Great. But, like, that's like a whole, like, it's not the same. So interesting to see how that comes together. Yeah. Well, anyway, this was fun. Chris, sorry we like railroaded you.
No.
Yeah. Big feelings.
I've watched enough of your podcast, so it's a little bit.
You knew it was coming.
Y'all are awesome. It's fun. It really. Love also just your take and insight and what's going on in healthcare. Sometimes it may seem a little generic, but then when I listen to your podcast, I'm like, wow, there's a lot going on. It's pretty wild and pretty interesting.
Wow. Flattery will get you everywhere. So thank you very much.
That's right.
Since we didn't let you talk at all, like, well, we did, maybe, you know, whatever. And now is your time to tell our loyal fans, whatever you want to tell them.
Just anybody who is managing a Medicaid system would love some help with access to specialty care. Please give us a call. Even if we're not a perfect fit, we'll recommend a methodology, a strategy, or another firm that can help you, because we want people to get access to specialty care. And that's what we do. We can talk to all our clients that we help wherever we can.
And if you want to hear Chris speak on a podcast that is not two people yelling at him, he was recently on the Provider's Edge, I think the most recent episode. So probably go check out and hear some more stuff, real stuff about Safety Net Connect. Not shouting. Thanks, everyone. Thanks, Chris.
Thanks,
for braving it.
Thanks, Keith.
See you later.
Signal us.
Find us on Signal.
Find us on Signal and send us all your secrets. Put us on your group chats. All right. Bye. See you later.